Hi, everybody, and welcome. It's Steve Simpson, and this is the Midwest Critical Care Collaborative meeting for March 10th of 2016. And we actually have the nicest turnout that we've had in a while. I hope I can keep people interested. I know this is a topic that's got everyone interested. I know that for a fact. Why don't I do this? Just occurs to me that it might be of use to you guys if I get my video on. Although I can't see myself, so it's always a little hard to tell what you're seeing and what you're not. Ooh.
We can see you from nipples up.
All right. Good. That's fair enough. That's a good way to go. So I thought what I do though, we've got a fair number of folks on, and some of you I haven't even met in person. But why don't we try this? Why don't we go round robin and have everybody say who you are, where you're from, and what you do? I think that's kind of a cool deal because if I haven't met you,
all of a sudden there seems to be a lot of
there is a lot of background noise, isn't there? I have a notion that someone sounds like they might be on a cell phone and driving. And someone just muted. Good, thank you. So what we want to do is we'll just say I'm going to go down the list because I don't know if you guys can all see the list of everyone who's on, but I think this will be fun for us to all talk to one another. So there is at the top of my list, I have waiting for name, so I don't know who it is that's trying to log in, but Misha Adams, looks like you're ready to go. Can you tell everybody where you're from and what you do?
Sure. So I'm a nurse. I'm a program clinical coordinator with Allina Health in Minneapolis, and my focus is on the sepsis work.
Perfect. And Angela Herbert? Although I can see not everybody has your...
We have a problem.
I can see not everybody has has your mic or your telephone turned on, so that's okay. It's quite all right. There's no requirement you have to speak. Dan Conyers, go ahead.
Hi, this is Dan Conyers. I'm the Director of Respiratory Therapy at the University of Kansas Hospital.
Cool. Delisa? Brienne?
Yeah, Brienne Rasmussen. I work at Allina Health, and I'm a nurse program coordinator with the sepsis program. So I work with Misha Adams and Emily, and we all work with Lee Toman and Jeff Dichter. So we have the whole kind of Allina group here.
Cool, perfect. And Brienne, you asked to be made the presenter.
I think that was an accident. I think that's why there was a lot of commotion. Then I tried to leave and come back, and
Gotcha. Gotcha.
Please be quiet that I do not want to present.
Okay. Well, you're welcome to. I got the slides all ready for you here. Denise, motion. Tell everybody where you are and what you do.
Hi, I'm from Bryan Medical Center in Lincoln, Nebraska, and I do some work with our sepsis team.
Cool. Eric Schoonover.
I'm trying to find the mute button there. Yeah, I work for a medical device company and just have a real interest in hemodynamics and sepsis in general.
Yep. And Eric's been a good friend of this collaborative for a long time. Michelle Foss.
Hi, this is Michelle. There's a couple of us on the call from Shawnee Mission Medical Center here in Kansas City. There's Kristen Frost, myself, and Molly McKinney, and I think Paula is also on the
Perfect.
Yes.
Yeah, I think Paula is on the line here. I agree. Jim Kaplan just signed in. Jim, so you don't know this, we're going around introducing ourselves. If you're ready to say anything, go right ahead. Maybe not ready yet. Jim is pulmonary and critical care specialist at Overland Park Regional here in Kansas City. Stephanie Lager. I think maybe people's microphones may be muted.
Hello, Stephen.
Hi, Jim. There you go. And I guess I just introduced you, so so we could leave it at that. Stephanie Lager? Nope. Deborah Mader?
Hi, I'm from St. Catherine's Hospital, Garden City, Kansas, and I am involved with quality management core measures, so interested in sepsis.
Fantastic. Glad to have you on today. Molly McKinney? Nope.
Molly's here at Shawnee Mission. I don't think she has access to her mic.
Gotcha. Perfect. And then a couple more people who have their mics muted. Rachel Merrick?
I'm on my phone.
Perfect. I can see you're on your phone. Do you want to tell everybody who you are and what you do?
Can you hear me?
Yes.
I am the quality coordinator at Labette Health. I do all the core measure audits and anything else quality.
Glad to have you on. Extra glad. Nice to talk to you. And Brianne Rasmussen.
I already talked.
Oh, you did. Right. That's right. I already got you, didn't I? Cool. And then Bob Badgett, I think, is muted. Go ahead. Now I see you're unmuted. Bob, tell everybody who you are.
Yeah, Bob Badgett. I'm an internal medicine faculty at the med school in Wichita, and in that role, teach QI to all the medical students in Wichita and all the internal medicine residents in Wichita. Sepsis has become a key process for the school because I think it's probably the best measure in the hospital setting for showing trainees how they got to work in teams to design systems and care for patients, and hopefully it contributes to our producing good trainees to go out to your good hospitals.
We hope so. We hope so. Cool. So that's down the list. That's good. It's a really nice turnout. I'm glad everybody could get on today. And so I'm going to go ahead with what I have prepared, and then we can have some discussions. And and by the way, so I have a few slides prepared, and then I know that Bob has a couple of really interesting slides to show us too. So I won't preempt or say much about those, except that they are definitely of interest. So if any of you have seen me talk about sepsis anytime lately, you know this actually is the title that I've been using for, the last year or so, or some play on this title, Severe Sepsis, Early Recognition and Rapid Aggressive Treatment. So as comes to Sepsis 3.0, my question is, does it help with that? And we will be talking about that as we go. So I think probably most of you who pay any attention to sepsis are aware that in late 2014 or sometime in 2014, the Society of Critical Care Medicine and the European Society of Intensive Care Medicine convened a panel of experts. Certainly, I have no quibbles with whether these folks are experts or not, from both of those societies to address a redefining of what is sepsis and what should the diagnostic criteria be. So this panel met sometimes virtually, just like we're meeting now, and sometimes in person, and used what they call all of a sudden it just left me the technique of polling.
Delphi.
I'm sorry. Thank you, Delphi. It just escaped my brain there for a minute. A modified Delphi process to hone in on what they thought a definition of sepsis should be. In addition to what they thought the definition of sepsis should be, they talked about should there be a redefining of the clinical criteria for making the diagnosis of sepsis. And that they did not do by a Delphi technique, but they did by use of several very large databases, including University of Pittsburgh Health System, Kaiser of Northern California Health System, the VA Health System, and others. And they made queries of that database in various different ways to refine down to the criteria that we're going to talk about today. And so there are several different things that we could or should say about these criteria, and I guess we'll do that as we go. The first thing that they turned themselves to was defining what is sepsis. And part of what led them to this is they recognized that even those of us who are well versed in the terminology of sepsis, severe sepsis, and septic shock, as we're going about our day-to-day business, as Jim is signing out to a partner, as I'm signing out to a partner, we very frequently use the shorthand of sepsis when we actually mean either severe sepsis or septic shock. Honestly, that's the way it is, because severe sepsis is more of a mouthful and a little bit, not exactly a tongue twister like Peter Piper picked a peck of pickled peppers, but severe sepsis is more to say, and so we often do just say sepsis. And they recognize that that is the case, but they also recognized, they also felt in this group that sepsis should mean something beyond merely infection, even beyond infection with systemic manifestations of infection. And so they wound up with this definition: sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. Pretty simple, pretty easy, and not that all-fire different from how we think about severe sepsis now. But you notice that they have dropped the term severe sepsis. No longer exists in this framework. They have also dropped the use of the systemic inflammatory response syndrome and the use of that combination of infection plus SIRS in the diagnostic criteria. So these are the diagnostic criteria from the Third International Consensus definitions for sepsis and septic shock. By the way, the shorthand for that is Sepsis 3. And so by way of introducing that, they considered the initial ACCP-SCCM definition, the paper authored by Roger Bone, to be Sepsis 1. The 2001 second conference, they consider Sepsis 2. And Sepsis 2 is where the Surviving Sepsis campaign and most people derive their diagnostic criteria for the moment. And then they define this as Sepsis 3. So I just built this little table that kind of summarizes what are the differences between our current definitions of sepsis, severe sepsis, and septic shock, and the proposed definitions by the Sepsis 3 conference. So, for the condition of sepsis, we currently use the criteria of infection plus 2 or more SIRS criteria, or infection plus having SIRS. So the infection plus SIRS concept, as I say, has been tossed out completely. What the Sepsis 3 conference calls sepsis is infection plus a change in SOFA score by 2 or more points. SOFA score stands for Sequential Organ Failure Assessment Score, and we'll address that on the next slide. Severe sepsis, we currently use the terminology of severe sepsis for infection plus SIRS plus organ dysfunction. That term is non-existent under the Sepsis 3 definitions. Basically, they felt that it was redundant to say severe sepsis, and they felt that we should not be including lesser, if you will, severities of illness in our diagnostic acumen for sepsis. Septic shock, as you all know, we currently refer to as infection plus hypotension that's unresponsive to volume administration. Septic shock is now, this is a slide I was going to put in here. Septic shock is now defined as a condition involving both organ underperfusion and cellular dysfunction, cellular or metabolic dysfunction. So that the criteria for septic shock that they propose are that we bump to infection plus unresponsive hypotension plus a serum lactate that's greater than 2. So you have your hypotension that's unresponsive, and you have your marker of cellular dysfunction here, cellular hypoxia or dysfunction. And so I think this table just sums up the differences between the two systems. Now, just to move on, this is how you do a SOFA score. And by the way, I am developing a survey that I'm going to be sending out to all of you guys, plus anyone else that I can get to take it, because I want to survey amongst doctors and nurses in various sizes of hospitals how many people actually use a SOFA score at present. My discussions with some of you and with other people indicate to me that the sequential organ failure assessment score is something that some people have heard of, some people haven't heard of, hardly anyone is using, and most of that use occurs in major medical centers, usually academic centers, if it's being used at all. I'm not sure whether it's worth it to go through how you calculate the SOFA score, except for just this stuff here. It involves respiratory parameters, cardiovascular or hypotension parameters, hepatic parameters, renal parameters, coagulation parameters, and central nervous system parameters. These are all mostly fairly easy to calculate, as in we are already calculating PF ratios often enough on our mechanically ventilated patients, and on a lot of other people who aren't mechanically ventilated as well, I should say. Hypotension, easy enough to determine what vasopressors are we on and how much of them are there. You know, vasopressin, by the way, is not on this list. We can talk about that later. Hepatic parameters, all of these are fairly easy, with perhaps one exception, and that's the Glasgow Coma Scale. So I don't know how many of you actually calculate a Glasgow Coma Scale on everyone you find who has mental status changes, but this is how you calculate a Glasgow Coma Scale. It's based on eye opening, and whether people open their eyes spontaneously to verbal command, to pain, or none at all, verbal response, and motor response. And so just to back it up, so the maximum score that a person can score on Glasgow Coma Scale is 15. So if you obey commands, if you're oriented, and if your eyes are spontaneously open, you get 15 points. So I'm going to back up just for a second and say, if you look at this on the SOFA scale, we're looking just for a drop below 15. So what that would mean is sort of any kind of mental status change, either a person's not opening their eyes spontaneously, or they're disoriented in some way, or they don't obey commands for movement. Any one of these things will get you below 15, down to that 13 to 14 range to get one SOFA scale point. All right? So the thing to bear in mind is, so what the authors of the new definitions are asking us to all do is to rememberize the Glasgow-Coma scale, and then to rememberize all of these calculations for a SOFA score. Okay, they knew that that wasn't likely to happen. So they thought, okay, we need something that's some sort of a screen for all these SOFA points. And they said, so they studied this in patients who were admitted to the general medical wards, medical or surgical wards. And they narrowed this down to 3 things and demonstrated that if you have 2 out of these 3 things, you have a mortality risk of, I believe, right in the range of 45%. So what are those 3 things? Glasgow-Coma scale of 13 or less, a respiratory rate of 22 or more, or a systolic blood pressure of less than 100. So if you have any of these things, or 2 of these things, it's fairly specific for mortality. We're going to come back to that issue, or that that particular thing about the new sepsis definitions in just a moment. So, what exactly does this affect? I didn't say when we were up on their definitions what they were looking for was a more specific definition of sepsis. In other words, they wanted definitions that when people meet these criteria are better predictors that they are likely to die. And the entire methods section of the Rasmussen paper, or Seymour paper, I'm sorry, not Rasmussen, but the Chris Seymour paper, the methods paper that they used to comb through the massive databases, the entire purpose of that was to identify a syndrome that is more closely associated with death than the current syndrome that we have. A second thing that they desired to do was that most of the people on this committee were fairly avowed enemies or dislikers of the concept of SIRS, which we will come back to here in a bit. Mostly the argument they have against SIRS is that it's too nonspecific. SIRS is not necessarily just caused by sepsis. And I've heard this argument for years and years and years, and some of you know what I would say about that argument about SIRS. And the simple fact is, so they give the argument, so you climb a flight of stairs, you get SIRS, you get tachypneic and tachycardic. So I go out for a run, I get SIRS. So I get a cold and I get SIRS. And that may or may not be true, by the way. But so they say SIRS happens for so many things. I get a surgery, I get operated on, and I have SIRS when I come out of the operating room. And that's what makes SIRS, in their estimation, so terribly bad as a marker related to sepsis. So those of you who know me know that my counter to that argument is this, that's a simplistic way of looking at it. I will admit that it is possible that Roger misnamed SIRS when he called it systemic inflammatory response syndrome. I think probably looking back on it now, one can see that, in fact, it might be better if it were named systemic physiologic distress syndrome, because in point of fact, it is a system-wide manifestation of some sort of physiological stress on the organism that causes these things to happen. When you climb a flight of stairs, you are putting physiological stress on your body. When you go out for a run, the same. When you go under the knife for a surgery, you are inducing a physiological stress. And so the specificity is not in Jim says SPUDS. SPDS. I've been saying speeds, Jim, instead of SPUDS. The SPUDS is pretty good. I like that. We'll come back to that momentarily. Nevertheless, you cause a systemic physiologic stress. And so my point about all this is the specificity for the SIRS or the SPUDS comes not from the SPUDS itself or the SIRS itself, but it comes from the cause. Now, we have this problem of working in a circular argument these days, because many people will look and go, okay, the patient has tachycardia and tachypnea, therefore they must have sepsis, therefore I should suspect an infection, therefore this circular thing. So now I have suspected infection plus SIRS, and then they go on to work it up, and it turns out not to be much of anything. So I understand this and recognize that the experts on this expert definitions panel work solely in intensive care units and solely in tertiary or quaternary academic medical centers. And so it's true, I cut them a lot of slack. It's true, the people they see that are in an ICU probably are under physiologic stress to begin with, and probably are tachypnic and tachycardic a lot of the time, and or having fevers, and or having high white counts, by virtue of the fact that whatever has brought them to an ICU is causing physiologic stress to cardiovascular and respiratory systems. I think that's great. I would agree. It's probably tough when one encounters SIRS in an ICU patient to determine whether infection is present or not. But it's a whole different ball of wax from the patient who is brought into the emergency room, who is lying on a gurney, who has an infection syndrome, and we'll talk about that in a moment, who has no other particular reason for severe physiological stress. Now, what do I mean by an infection syndrome? I'm talking about here, the patient is complaining of pleuritic chest pain, a cough with purulent blood-streaked sputum, and maybe the exam shows bronchial breath sounds. This should be a suspected infection. This ought to be suspected to be pneumonia. Once you've established that I have a suspicion of an infection, then you can check whether the SIRS is present and whether the organ dysfunction are present if you want it to have specificity. Similar syndromes might be severe cellulitis, fairly easy to recognize. Similar syndromes might be a peritonitis or peritoneal symptoms. Similar syndromes might be flank pain with costovertebral angle tenderness and dirty urine that would suggest pyelonephritis. So the SIRS was never intended to be the trigger for so-called suspected infection. The SIRS was expected, and this comes pretty much straight from Roger Bone through me, I guess, is that it was intended to be evidence that this particular infection syndrome is causing physiologic distress. Okay, so nevertheless, so that's a fairly large digression there, but it is to say that it perhaps may have been a mistake to remove SIRS from our diagnostic criteria. What I am certain is a mistake in removing SIRS is this, that the language we use shapes how we think about a problem. It's for this reason, parenthetically, that I don't ever let nurses or residents tell me bed 7 has a fever, or bed 7 disconnected their ventilator. I just don't allow that. I say, do you mean to tell me that the nice lady who is lying in bed 7 right now is having problems? Or do you mean to tell me that Mrs. Smith, who is occupying room number 7, has a problem? And I don't like the notion of talking about people as beds, because I think that it becomes dehumanizing, and if we continue to do that, we will dehumanize the entire circumstance. In much the same way, I have concerns that if SIRS is no longer part of the sepsis dictionary, that we will begin to behave less aggressively when we see infection and SIRS than we currently do. This was not, or this is actually in, I've put it in a letter to the editor of JAMA that responds to these things, and I think it's an important thing to keep in mind. Okay. So now, now you've heard the Steve Simpson version of what I think is a little bit wrong with this. So again, just to recap, I think that the absence of SIRS is going to provide problems in the sense that I believe people will wait longer to intervene than they currently do. Secondly, the new definitions are actually not screening tools. Even though they tried to make the QSOFA a screening tool, it's not a screening tool, it's just an easier to use version of the bigger tool, which is a predictor of mortality. And so our new definitions of sepsis are much more likely, or not much more, somewhat more likely to be associated with mortality than is the previous syndrome of infection plus SIRS. So that's to recap my thoughts. Additional thoughts that are very important to us, especially those of us who actually do have to deal with CMS core measures. Now, not all of our critical access hospitals will have to do that, but I think most of us on the phone call today actually do have to deal with CMS core measures. And it's of crucial importance that the CMS definition of sepsis is the definition that we have been using since approximately 1992, for sure since 2001, since the Sepsis 2 conference, and it has not changed, and there's no indication that CMS is moving rapidly to change it. Secondly, ICD-10 diagnoses have not changed, and there is no indication that ICD-10 is moving to rapidly change its diagnostic identifiers in order to meet this new definition. So let's skip down to the last point for a minute. What that means is that we really need to get together with ourselves and decide, is it important to us to do well on these core measures or not? And if so, then we probably need to stick to the old definition, and we should probably not move at this particular point, because you can imagine the havoc that it will wreak if one guy means infection plus hypotension plus mental status change when he writes sepsis, and if another guy means infection and SIRS criteria. Sean Townsend, who was one of the proposers for the core measures to CMS, has looked at this, and actually has looked at the CMS core measure in depth, and pointed out to me the other day that there is no way to do what we would call a crosswalk from the new criteria to the old criteria, because they simply are different enough that it's not really possible for a coder to make the distinction. So that by itself is going to be an issue. And then the last thing, though, that's of crucial importance to me is that we absolutely have to continue to screen and find people who have serious life-threatening infections by looking at some sort of signs, hopefully early in the course of their infection, where we can intervene with the most hope of benefit. I think that's all that I'm going to say except for this. Some of you have seen me give this quote before, but I am still stuck on it because I think so much. It's so much of what we, those of us on this call, are trying to combat in our own institutions. And this is a quote from Niccolo Machiavelli from The Prince, which was written somewhere in the early 1500s. And he was just quoting the doctors of his day, but they said that it happens in hectic fever, which is probably their word for sepsis, that in the beginning it's easy to cure but difficult to detect. But if you let it go, by not detecting or treating it in the beginning, it becomes easy to detect but difficult to cure. And I would propose that what we have done with our new definitions is actually moved the new definitions farther towards the easy to detect but difficult to cure side of the spectrum. And that's where we or they have left it. Now, I apologize for this. I will send it out via email. But I had intended to put a link in this talk to an editorial that actually I wrote, but expressing the response of the American College of Chest Physicians to the new definitional change. And basically it comes down to this, that editorial, which, like I say, I'll send a link to it out via email after this meeting, or later today sometime. But basically, there are several key components here. Number one is, as I say, these are mortality indicators, not early sepsis indicators, or not necessarily even sepsis indicators. Number two, the condition really hasn't changed. There is no difference in what infected patients are experiencing or what we are seeing. Only the dictionary has changed. But number three, we worry that the dictionary has changed in such a way so that it promotes waiting further down the cascade in order to identify and qualify people as septic, rather than beginning early in the time course of the illness. And number four, that these definitions have not in any way been prospectively demonstrated to reduce patient mortality. We know over the past decade that there are multiple prospective studies demonstrating that the older definitions combined with rapid aggressive treatment are reducing mortality from severe sepsis year over year, and that's on a global basis. Every study that's been published in the last decade from every corner of the earth demonstrates that sepsis is becoming more common, or at least that we're recognizing it better, but that we are reducing the mortality from it by use of the older definitions. So it really doesn't make a lot of sense to change course in midstream here and move in a different direction. It especially doesn't make sense if you stop to think about that even well-documented, clearly, obviously beneficial things in medicine take on average 18 years to become part of the standard operating procedure. Example, beta blockers in patients who have had acute myocardial infarction. Still, substantial proportions of people who've had an acute MI walk away from the hospital without a beta blocker, which clearly has been demonstrated to save lives in the post-MI period. And we've known that for 20 years now. Severe sepsis probably never joined the mainstream medical thought process until the Surviving Sepsis campaign, frankly. It was present. We had definitions about severe sepsis since 1992, but nobody knew about them until Surviving Sepsis campaign began to get out there and beat the bushes and get people to recognize and treat sepsis early. And so if you put it that way, we're only a dozen years in on this particular definition of sepsis spread across the world. So the way I see it, we have not given this particular, our current definition of sepsis, time to become fully incorporated and be active in our day-to-day existence. So there you go. Those are the new definitions. This, of course, is going to be posted for anyone to be able to look at. What should we be doing now? What I am promoting for my institution is that we stand pat. We have something that's working. We have something, and even with our current definitions, we still have failures to recognize from time to time. Actually, I shouldn't say from time to time. We have daily failures to recognize, but we continue to make progress. And we do have to meet CMS core measures, and it doesn't make sense to jump in with both feet just yet. Now, the authors of the new definitions, in deference to number of people, do recognize that these definitions need prospective validation so that we can know whether they are going to make some sort of difference or not. And the last thing that I'm going to say, I think, before I hand this over to Bob, because I really want you to see the slides that Bob sent me. The last thing I'm going to say is that you have to remember that I believe that the members of the panel were looking at sepsis from the mindset of people who are trying to come up with additional drugs or additional means of treating, and they want the syndrome to be more highly associated with mortality, simply because it makes for a better signal-to-noise ratio in research studies when we begin to apply one drug or another to the patients. And I think that is a laudable thing to do. And I think there is a certain amount of sense to that, but I believe that they have neglected to realize that the vast, vast majority of patients with sepsis are not people that they see in their academic medical centers with highly trained sepsis specialists, but are people that come to the average hospital in the average town, in the average state across the world. And so I think there are different potential uses of a sepsis definition that have been neglected in this particular redefining. All right, Bob, I am going to change over to you if I can find you here in the list. Where'd you go? There you go, down at the bottom. So I am clicking OK to make you the presenter. So if you will take that, that would be nice.
I had a question back to you, if I could.
Sure.
Is the American College of Chest Physicians, the ACCP, I want to make sure I was understanding what you were saying, are they going to take an official stance on Sepsis 3?
They have taken an official stance, and the official stance is in the editorial that I refer to.
Okay.
And I was the official editorial writer for Chest. Additionally, I can tell you other important societies that did not endorse. By the way, if you look at the bottom of the paper, those of you who who have access to JAMA and can look at the paper. If you look at the bottom of that paper, you'll see a list of societies that have endorsed the new definitions. Chest is not one. The American College of Emergency Physicians is not one. The Infectious Diseases Society of America is not one. The Society of Hospital Medicine is not one. And so even though they say over 30 societies around the world have endorsed, if you look at who the societies are, you will see that there's some major people missing from that list.
Okay, great. Just wanted to set up the tension.
Yeah.
So thanks for letting me toss a couple slides in here. So the two things I was after is, I think we've all seen Kalkinen's study in the New England Journal last year where SIRS had a pretty decent sensitivity for predicting death. Why did it go so bad in the Seymour study that just came out in JAMA? And the second one is, so Steve's editorial was also picked up by the Massachusetts Medical Society's Journal Watch, and so he had a nice podcast on that where he was interviewed. And so I wanted to look at that argument he was making that the switching to the new criteria would diminish sensitivity. And so these are the two things I want to see. So this first slide just compares the original to the first study versus the second. And you can see they're very different patient populations. The Kalkinen study, they all had organ failure, almost a quarter died. The Seymour study is very complicated to look at. It was such a huge database, they had to come up with a way to identify these patients because they couldn't necessarily read each chart by hand. And so it's, did they have infection as based on suspected infection based on whether order sets were, cultures were ordered, plus antibiotics, and these two events occurring within 2 to 3 days of each other. So as you can see, that's a little bit of a wobble in that definition. And so a lesser rate of these had SIRS and a much smaller mortality. So now let's look at their results. And the results are a little bit hard to find, but first looking at the Kalkinen study from the New England Journal, so remember infection plus organ failure, the SIRS had a very nice sensitivity and a pretty good specificity as well. But moving on to this different population where there's no longer organ failure, okay, now the Kalkinen is still at the top. Now we got the Seymour study, and you had to kind of dive into their supplement to get these numbers. And I just took their non-ICU numbers. And so you can see the sensitivity fell quite a bit, down to 64%, specificity 65%. But yet, if you look at the Q-SOFA that they propose, it was less, at 55%. Now, it did achieve the higher specificity that the investigators want, and as Steve was saying, that was sort of their goal. They wanted a higher signal-to-noise ratio. But you can make the argument back when your disease is lethal and your treatment is not, or not often, giving fluids, you actually want a high sensitivity. It's sort of a basic epidemiologic principle that early on you want high sensitivity. So that would be, I thought it validates Steve's concern that you're going to have less sensitivity. Mm-hmm. So to me there's a couple of questions that are raised here. For example, one is, I don't really understand the Seymour population, and I'm wondering, what are they dying of? Are they all dying of septic shock? Is it possible that the sensitivity is low because they're dying of other things, because they didn't all convincingly have infections? Mm-hmm. Then the second thing that, and someone else on the call may know better than I, has there been good study of the timing of these markers? So the SIRS wasn't sensitive when studied in the Seymour study, but yet it's not clear when that SIRS criteria were grabbed. If you follow them over time, does everyone who dies of septic shock, it seems like eventually they all go through SIRS criteria, and when they enter SIRS criteria, are they still salvageable? And I would like to see more study comparing SIRS and SOFA in that regard. At any rate, those are the questions that still were left with me, and so I don't know if anybody had any thoughts about these two studies and then the comparing of the SIRS and the SOFA.
I think that's really nice what you've done there, Bob, and I think the thing that stood out to me in the Seymour study really was so they used SOFA, which is an organ failure assessment score that was specifically defined or specifically developed to find life-threatening organ dysfunction. So they compared this one showing presence of organ dysfunction only to infection plus SIRS, which, by the way, it doesn't make sense to me because our current definition is infection, SIRS, and organ dysfunction. So why did they not compare those two head to head in their database? Doesn't make sense to me at all. And so we are going to be using our own database, which has just under 10,000 septic patients in it now, to investigate that exact question. So in essence, I think what you've done is help us out to show that infection plus SIRS is reasonably sensitive. What they claimed in the Seymour paper is that infection plus SIRS and QSOFA are pretty much about the same sensitivity, but I think they were comparing a little bit apples to oranges, and what you've done is compared oranges to oranges and showed that really sensitivity is quite good. Yeah, I do understand the trouble that they have in defining their infected population. It's a whole lot different if you can, as you've heard me talk about before, if you can somehow read the mind of the person the doctor who's seeing the patient and get, this doctor's looking at this infection syndrome. That's one thing. But when you're doing this in a retrospective database, we have done much the same as they have, which is to say, well, look, if this doctor ordered blood cultures or cultures of other potentially infected body fluids, that means they're suspecting infection. Or if this doctor put in an antibiotic order, they are suspecting infection. And so we called the time at which an order for either one of those things occurred in the charts as the time that there's suspicion of infection. And so I understand pretty much exactly what Chris Seymour was doing there, but you're right, it's a little tough to get a handle on what are they calling infection. On the other hand, even in prospective studies, it's often difficult to get a handle on what they are calling infection. In a prospective study, you just say, I have high suspicion of infection for this patient, so I'm putting them in the study. But retrospectively, it's just a little harder. But this is really cool what you did there, and I think it supports pretty much what I've been saying all along. Jim Kaplan, are you still on the line?
I am.
I'm curious to know your thoughts about all of this. And you can disagree with me by all means.
No, I feel that unfortunately QSOFA and SIRS have equal flaws. I had lunch with a surgeon yesterday who said that when he runs up to the 4th floor to see his patients and can't remember which room to go to, he has 2 QSOFA points, and yet he knows he's not septic. He's confused and tachypnic. It's no different than the argument that we had against SIRS, which was that by itself it's a number of physiologic parameters that you want to have an excellent sensitivity, and you don't necessarily care. Well, that's not true, but I mean, you care less about the specificity because that shakes out, and if you miss early treatment, that's a problem. Now, one of the things, as I understand, those assembled at this at Sepsis 3 brought up is that the the spectrum that we used to think that all people go through, from SIRS to sepsis to severe sepsis, etc., is a immutable process that always happens, and they argued with that concept.
True.
Do you have any comment on that? Because I think actually that depends on when you see the patient as to whether you believe that's a process or not.
Exactly. I think you hit the nail on the head there. If you're looking at a patient who already clearly has enough organ dysfunction that they're coming to your ICU, or is in your ICU with some organ dysfunctioning to begin with, that you may not see that same evolution. Now, I can't swear that everyone goes through the evolution. In fact, the Kalkanen study here would suggest that not everyone does go through that. And the whole point of their study was to say, look, we've got people with infection and organ dysfunction who don't have SIRS. And I'll buy that, and you know that's true. I know that's true. We've all always known that is true, that not everyone can even manifest SIRS. What I'm intending to do with our database is to find out is if we look for people in the ER who have SIRS and then get the cultures, like I said, what proportion of people have that fairly early on? We know that not everyone does. In fact, we've been monitoring in our ER very carefully, especially after the core measures came to be. And there are a fair number of people who, when they show up at the ER at triage time, don't actually fall into the category of SIRS, but do once you put them back in the bed for whatever reason. We don't know why this is, but it seems to be the case. I think we don't have proof, though, Jim, as you have alluded to, that you clearly go through, well, I've got an infection, and the next thing that happens is that I manifest the physiologic stress as SIRS, and then if it gets worse, then I go on to get an organ dysfunction. There's probably much more of a continuum amongst those things, with a little more, in some people, a little more organ dysfunction before the SIRS, and in some other people, a little more SIRS before the organ dysfunction. It wouldn't shock me, but I hope to find out now that we've got a rather large patient cohort to look at. But what I do know is that it's probably, for my taste, and I believe for saving lives, it is probably the wrong thing to make the end point of your criteria be this is more highly predictive of death. And one of the other things that I said in my editorial, I think, was this, that acute myocardial infarction and acute coronary syndrome are far less deadly now than they were 20 years ago, 30 years ago when I first got into medicine. They were probably fatal. In-hospital mortality rate was nearly 15%. Now we're down below 5%. But you don't see anyone screaming to redefine acute coronary syndrome because it's no longer as deadly as it once was. And so likewise, I think that we haven't made enough progress using our current definitions. We've made progress, but not enough. And I think we make a mistake if we want to change the course of the boat in midstream. Those are my thoughts. But I will say, practically speaking, again, I think the practical thing to do at the moment for those of us who are subject to Joint Commission and CMS core measures is to hold pat for the time being, at least in the United States of America, because we need to. Anybody else have things to say? How about nurses that are doing screening? Nope. No one wants to speak up?
Here at Shawnee Mission, we are actually sticking with the old guidelines for education because we're rolling out housewide sepsis screening. We're doing a lot of sepsis education and nurse competency days, and for new higher orientation. So we have all these different educational rollouts right now regarding sepsis, and the screening tools that were built by our corporate department are all reflective of the old definitions. So we're sticking tight right now with and moving forward with RN education just regarding the old definitions still.
Okay. So some other people are thinking similarly to me, at least on that account. And I think, it's hard to argue with, it's like the IRS. CMS and the IRS are much the same. They're the big dogs, and they get to tell us a lot. So that's just the way it goes. So it's the end of the hour. So I know that everyone needs to go. A fair number of people have dropped off already. I just thought I would say, so here I have this problem next month in that Chest World Congress takes place, and I'll be on an airplane to China on the second Tuesday of the month. So I was thinking about maybe moving us to April 7th for our meeting. I will get out an email about that. Does anyone who's still on the line object to that in any way? Nope. I hear no objections. So I will get an email out to everyone about that. And that will be an evening, a 6 p.m. meeting, because it's an even month, so we'll meet in the evening. Cool. Well, thanks everybody for getting on. I hope this was useful. We can continue to talk about it because I believe it's going to be an ongoing discussion here. I can assure you, I do know this much, that the Surviving Sepsis guidelines are likely to use new definitions, and I'll tell you exactly why. It's because the new definitions were created by SCCM and the ESICM, and those two entities own Surviving Sepsis Campaign. So I think regardless of the discussions at the Surviving Sepsis meetings, we basically have been told that we're going to use the new definitions when we put out the new guidelines. So there you have it. It's going to be an ongoing discussion. So thank you everybody for joining. Again, this is Midwest Critical Care Collaborative for March 10th, 2016. I'm Steve Simpson, and we will see you all next month.
Thanks.
Bye-bye, everybody.
Thank you. Bye.